Welcome back on Iron's Health Talk with Dr. Akram. Today we are talking about ischemic heart disease and coronary artery bypass. And on our studio, I have a special guest here who's Hogo, and she is a student, and three other guests joined from Skype. They came, it's Ahsan who came from USA, and two consultants, cardiac surgeons joined from Oxford. That's Shakeel and Vivek. They are all with us, and today, so far we have talked a little bit about coronary artery disease and what we could do, the initial bit. Now we're going to go to the treatment next. And if anyone joining today in this program at this time, please be with us, and we're going to talk more about it. And first of all, I'm going to take a caller, and there's a caller online. Hello, sir.
Hello, good evening.
Good evening. What's your name, sir?
It's Mahmood Rahman.
Mahmood Rahman. Yeah, okay. Thank you very much for calling us. Where are you calling from? Which part of are you from?
I'm calling from Bath.
Are you calling from Bath? That's excellent.
Yes.
What do you do generally? Are you a medical?
I'm retired now. I'm a university lecturer.
Are you retired?
I'm a chemical engineer. I'm retired.
Are you retired university lecturer? Okay.
Yes.
What is your question, sir?
I had a heart bypass operation in 1995 when I was only 40 something, and there was 4 bypass grafts were done. The last angiography I had, 2018, I went to local hospital with chest pain, and they thought I had a heart attack. So I was sent to Bristol Royal Infirmary, and they said there's no heart attack. But anyway, they did the angiography. Then they found all the 4 bypass grafts are still intact. So that's very good news. Now, while there, they increased my statin from 40 to 80 milligrams. Now, it is, I think we found out through my cardiologist, Dr. Mansfield, in Royal United Hospital, Bath, that the combination of diltiazem, the other medication I have, with statin causes some difficulties, but which is not very clear. I have some symptoms like hot flashes, my head getting hot, some other symptoms, peculiar symptoms like getting, feeling blood, vision, this sort of thing. Now, I have then, with consultation with my cardiologist, reduced the statin to 20 milligram now. Now, with your discussion, Dr. Chowdury, the way he discussed, the higher doses of statin looks like helps to, if there is any plaque buildup. So, my main medication is diltiazem 90 milligram twice daily, and aspirin. I take 60 milligram isozorvite mononitrate, and these are the main heart medications. If you could advise me if I need to increase the statin or any other medication I need to keep me well for the next.
Thank you very much, sir. That's quite important and quite interesting question. I think it's Ahsan Chowdury it must be the best person to answer that.
Let me tell you that in your case, I do agree with your cardiologist that the goal, if we can achieve the LDL, the target below 70, and that will be probably, you know that from the Prove It trial that it is better. And if you look at the LDL level and the event rate, the lower the LDL level, the event rate is lower. Now, in your case, question is how much dose is good? Whatever dose you need to achieve that is probably the goal. But we, the South Asians, we have a problem. And with our genetic constitution of the enzyme that metabolizes the statin, that is the cytochrome P450 system. I did my PhD from Southampton University, and that was my life, that whenever you challenge a substrate that uses that enzyme, the enzyme expression is a problem, and that because it's less. and therefore the side effects with a similar dose is going to be higher for South Asians compared to Caucasians. So the trick that we can do, try the lower dose, 40 milligram, see where is the LDL, or you can do a combination with ezetimibe and then see whether the LDL goes down. It sounds like you are not someone who is intolerant to statin, because intolerant patients, they cannot take any statin. But you are able to take, but the higher dose can give you problem. And diltiazem, for example, is a drug that can cause the interaction so that it is also a inhibitor for the enzyme. So you may have a pharmacokinetic drug interaction with the statin giving more intolerance or side effects with the same dose when you are using diltiazem. There is a potential. Now, in the totally intolerant statin, we use the PCSK9 inhibitors, which is totally different mechanism, and you probably don't need that. I would try this combination first, but I would discuss with your cardiologist. I'm not your cardiologist, but that's the strategy I will take.
Thank you very much, Ahsan. Are you happy with the answer, sir? Thank you very much. I think we dropped the caller. Thank you very much for calling us. Anyway, Hugo, you wanted to ask some questions, no?
Yeah, I've got a question for Dr. Vivek, if that's possible.
Yes.
Are there any occasions where you would refuse surgery, and why?
Yes. So I think if you look at angiograms, and that is how currently traditionally decisions are made about who can have stents and who can have a bypass operation, the decisions are based on what's called an anatomical basis. So we look at the angiograms, and the coronary arteries may seem very good to do bypasses for, or they may be quite diffusely diseased, and that is one of the reasons why we may choose not to, because the possibility of getting them benefit is quite low, and putting them through even though it has become a lot safer, the operation still carries a risk. And it may be that the risk is actually far more. So the two things that we have to weigh out is what benefits they stand to gain and what risk they face. So the risk can come from the procedure itself, or the risk can come from what patients are like. Patients may have various comorbidities, and there are patients who the risk may not be 1 in 100 chance as we quote normally, and the risk may be much higher because they have other problems like lung conditions, they may have kidney problems, they may have liver problems, and various other conditions that may cause them to be a much higher risk person for a standard operation. The procedure itself is probably similar for everyone, but their ability to withstand that operation may not be the same. So in that case, we have to make a careful assessment, and if whether the benefit they stand to gain out of all this is really worth taking and really worth exploring. So that is one scenario where we may say, no, unfortunately, bypass is a very high risk option for you, and you may have to go either for stents as probably equivalent, or maybe a better considering the circumstances, or continue with medications. And it all depends on how the patient is. Sorry, I'll keep it brief, but we could.
And Vivek, that we are calling the heart team approach now.
Absolutely.
We are in the same team.
Absolutely.
In the same team. That's good.
That's the important thing, isn't it?
So you got the ideas, and so it's
Yeah.
like it's not everyone who's been referred to these cardiac surgeons get the surgery,
Yeah.
but sometimes the cardiac surgeons or anesthetists can refuse because the patient is maybe not fit for the operation, or the operation is not possible because the block or the plaque is in funny place and they can't operate on it.
Yeah.
So do you want to ask some more questions?
I've got a question, but it's a bit different.
Okay, you can ask it.
Are there any other minorities that would possibly be at a high risk of getting the disease as well?
So we talked about so far the South Asians are vulnerable for this heart disease, and Hugo's asking whether if are there any other population or any other minorities are in higher risk. What about?
I can tell you the U.S. experience because we have the Mexican American population, we have the Indian American populations, and what we know, and I see the same trend that Dr. Salim Yusuf, who was in Oxford before and then moved to Canada, and his studies, he showed that all these risk factors, the traditional risk factors that we know about that relate to the coronary artery disease, aside from the genetics part, if we get that early in our life, then we encountered this problem, the coronary artery disease, earlier and also in more severe form. And we see that trend in every minority communities. We see that in Indian Americans with diabetes, obesity. We see that in Spanish population in the US. And it is like, to me, no more a surprise that when the risk factors come into play and appear early and we don't take any preventive measures, it's going to play out the same way.
Yeah. Shakeel, do you see any difference in the Middle Eastern population? Do they have any difference in?
Yeah, I think the Middle Eastern population has have quite nasty disease as well, from my experience. I totally agree with what Dr. Chowdury has said. I would like to add that, your socio-economic condition does play a role as well, because it has been seen that in poor, deprived areas, the incidence of heart disease is quite high, because a lot of them are not aware about their health needs. They don't go to the doctors for regular checkups. A lot of them live on fast food because it's cheap. There's lack of exercise, lack of education, and the incidence of diabetes, obesity is very high in those populations. So as Dr. Chowdury has said, that's a similar experience in UK as well. Fortunately, we work in a very good part of the country, which is Oxfordshire, and you can actually see a distinct difference between the demographics of the patients we get from Oxfordshire itself and from outside Oxford, like people who are coming from big cities like London, very crowded areas. So I think this is something which is really important.
What kind of preparation you make before surgery, Shakeel?
So before surgery, one is preparation of the patient, obviously, and preparation of the surgeon. So preparation of the patient is, you need to make sure that the patient is fit for an operation. So how do you determine that? So you take a thorough history to see whether there are any major comorbidities. Then you perform some clinical examinations, and finally you do some tests. So fortunately, in most of the cardiac centers in the world, there are pre-op assessment nurses who actually make sure that all the T's are crossed and I's are dotted. So basically, the patients have blood tests, patients have chest X-ray, then ultrasound of the heart, which is known as echocardiogram. And if any of these investigations pick up anything bad, then we do further investigations like CT scans or any specific tests that's needed. Finally, it gives us an idea about the risk profile of the patient, and we use a risk scoring system, which is known as the Euroscore. And when you enter all the data that you have got from the clinical exam and investigation of the patient, it gives you a rough estimation of the risk. For example, if someone is under 60, coming for a bypass operation, doesn't have any history of anything at all, no major comorbidities, his risk of death is around 0.5% according to the Euroscore. The same individual, if he has other problems like diabetic, on insulin, has lung disease for which he's on inhalers, and he has any other major problem like neurological problems, his risk profile goes up, like his risk of death can be 4 to 5%. So, these are really important to assess the patients properly. And when I say, the other thing I said about preparation for the surgeon, I think it's really important to be focused before you are going in for a surgery. So personally, what I do is, when I'm scrubbing for the operation, I try to rehearse the operation in my head, in my brain. And I find it quite useful because you are quite focused, and it's important to get a good night's sleep, eat properly. These are all important things. For you, it's just another operation, but the person who is having the operation, it's his life at stake. You have to think about the long-term and the short-term outcome of that patient. So yes, I think it's really important for the surgeon to be prepared for the operation as well.
That's quite
very well put, Shakeel. Very well. Yeah.
That's quite interesting. That's quite interesting. Yeah. Let's talk. Do you have any more questions you want to ask? You can ask Vivek anything.
Oh yeah. Okay. So what exactly would you do to the artery during the surgery?
Sorry, is that for me?
Yeah, he's asking Vivek.
Okay. Right. Okay. So yeah, like I was describing earlier, the arteries are quite fine. So most surgeons would use magnifying glass. So when we are in theater, now techniques may vary, but effectively what a bypass operation is doing is creating a bypass route for blood flow to flow around the obstruction or the narrowing that is in the artery. So we look at these arteries, we assess where, based on the angiogram, where the bypass needs to go so the downstream blood supply is clear. And that's where we then open up this artery, tiny incision, probably about 4 millimeters, 5 millimeter long incision there, which is a
so
cut
you need
in the
to
artery.
open into the chest before that, isn't it?
Yes, of course. Yes.
Okay.
So most bypass operations would be done through the chest. And through the middle of the breastbone, the sternum. Some surgeons do use the spaces between the ribs to go get into the chest. And then we most commonly, what blood supplies we use to divert to the heart are the mammary artery, which is the arteries that run along the side, the breastbones on the sternum side. Which is the left mammary artery is the most commonly used conduit. Conduit meaning something that provides blood supply. And then the next commonly used is the vein from the legs, which is the saphenous veins. And the leg has a dual system, so the long saphenous system can be used for that. Then there are other things like the forearm arteries and the right-sided mammary artery can be used as well. But these are basically ways that can be used to provide blood supply down the stream. There, at surgery, we would get to the heart. Most people would arrest the heart. We use a bypass machine to support circulation during that time.
So during the operation, you stop the heart physically?
Yes.
Okay.
Well, most people would do. I think that's the most common way to do the operation. Although if you go to India and if you go to Bangladesh, people are very skilled in doing off-pump operations, which is also done in the UK, also done in the US, but by a far lower number of surgeons, where the heart is kept beating, but it can be positioned and it can be stabilized using special devices. And once we have access to those arteries, we open up the artery and we use very fine stitches, very fine sutures to attach one end of the artery or vein that we are using as a conduit. And then the other end is either attached naturally, as in the case of the left mammary artery, it already has a natural supply which is not interrupted, so it's a different pathway for blood to flow around. Or if it's a vein or another artery or a different kind of conduit that we are using, then that has to be attached to the aorta, which is the big artery leaving the heart with the pure blood supply. Then once we're done with that, we make sure that there isn't any bleeding, make sure the heart is functioning okay, make sure the bypasses are working all right in terms of what they're meant to do, in terms of providing the blood supply. And then we close the chest, and that's the end of the operation. But it's the start of a journey for recovery period for the patient thereon. As you can imagine, it's a big operation to get through. But that's what we do in theater, and that takes somewhere between 3 hours. Most operations would take about 3 hours, some take longer, 4 hours. Yeah, that's about it.
I want to ask a special question this is for Shakeel. While you are operating, you stop the heart. How do you supply blood to the other part of the body during that operation? What do you do?
Yes, there is a solution we call it cardioplegia solution. So basically it gives nutrition to the heart, and it also gives some electrolytes which stops the heart, like it's very high in potassium. And some people, what they do is they reduce the temperature as well. So like personally, normally a normal human being would have a temperature of 36.5. But when I operate, I reduce the temperature to 32 degrees. Some people reduce to 34 degrees. So you are protecting the heart in many ways. You're reducing the temperature, which reduces the metabolic demand of the heart. And then you're giving some metabolites to the heart every 15 to 20 minutes. And also you are giving some electrolytes to keep it still. So when the heart is cold, it's not beating, the oxygen consumption of the heart is low, it needs less nutrition. So this is how we do the operation. And if you look statistically, I think only 10 to 15% of surgeons around the world do beating heart surgery in the whole world. Whereas if you go to countries like Bangladesh and India, it's slightly different, as my colleague has said. The incidence of off-pump beating heart surgery is more in those situations, in those countries.
And you have a special pump which supply blood to the brain and other part of the body during the operation.
It's a heart-lung machine. So basically, when the heart is stopped, the lung is also stopped. The heart-lung machine does the function of the heart. So it has a pump. At the same time, it has an oxygenator. So it works as an artificial heart-lung. And it's safe to do operations like that. You can stop the heart for a long time by giving nutrition, doing all the right things. You can keep it alive, and you can the heart starts to beat as soon as you restore the supply of blood to the heart. It's quite interesting.
It's quite interesting. It just start beating afterwards. Ahsan, what is coronary artery bypassing? Sorry, coronary artery spasm. Sorry.
Coronary artery spasm. Okay, so the artery has these layers called the endothelium, the muscle layer, and then another layer, and that constitutes the whole artery. The muscle can be sensitive to stimulus and can go into what we call the narrowing. That's called the spasm, and by definition, this is like transient compromise in the flow and then restoration of the flow. And it could be a variety of reasons. Some people are sensitive to the coronary artery spasm. Sometimes when we work in the coronary artery with oil and balloon, we see a spasm. So it could be a variety of reasons.
Do they get angina?
But usually this can give you a transient compromise in flow, and because of that, one can get chest pain we call angina.
Angina. Oh, okay. That's quite interesting. So it's coronary artery spasm. Now, how is life after bypass surgery? Vivek, what would you like to say a little bit about it? We got on 3 minutes left.
All right.
There is a caller as well. I'm going to get the caller as well. We got 3 minutes left. Let's see what we can do with him. Hello, sir. Hello.
I spoke earlier. I had a question left which I couldn't complete.
If you could ask it quickly, we got 3 minutes left.
Okay. Although all the 4 bypass grafts are open, I still got chest pain time to time, and I have been hospital many times in the last 20 years. And I was told recently that I've got which is called micro small vessels are blocked, and that's why nothing could be done except medication.
So you had heart surgery.
And whether anything can be done other than this.
Okay. So you had heart surgery, and it's all repaired. Now you still get chest pain, angina. Who's best person to answer for this question? We can ask the surgeon, or we can ask the cardiologist.
Chowdury probably.
I think Chowdury probably.
Okay,
so the macrovascular, the macrovascular means that the vessels that we can take care by balloon angioplasty stent, but microvasculars are like really very minute vessels, and then we cannot do anything much in terms of mechanical intervention, where we use the pharmacological intervention, and those drugs that dilates, and addressing this will be like nitroglycerin. Addressing there will be calcium channel blockers, potassium channel openers, all these that address the microvasculature. Sometimes people use those that changes the metabolism, like alteration in the metabolism. We use ranolazine also, but these are all the pharmacological agents that we use for the microvascular. There is also a good paper on the preconditioning. That means that you get this and then you actually precondition and you actually increase your exercise tolerance.
Okay, thank you very much. We're running out of time. Sir, you can always email us, or you can always send a message on Facebook or Twitter, and we will answer more in detail about your question. I can always ask my guest speakers, and they will be more than happy to answer. We're running out of time. Let's quickly say what's life after bypass surgery. Vivek, would you like to say something about it?
I think most people would find that they benefit. It does take some time to recover from a major operation as a bypass. So it takes somewhere between 2 and 3 months for most people. Some people may need up to 6 months to get back to their feet properly. But most people would then find that they're able to do much more. Their risk of heart attacks is lower. It doesn't mean that they're off their medications. The surgery is helped by medication. So yes, unfortunately, the medications carry on as well. But that is how most people, active working people, should get back to their work style. And most people would actually find benefit. So, and people are unrestricted once they recover from the operation. So most people should be back to their normal self and be able to carry on with their life.
That's great. Thank you very much. Thank you very much, especially Shakeel. Is a consultant cardiothoracic surgeon who joined us from Oxford, and Vivek also from Oxford, and Ahsan from USA. It's amazing to be with you. I wish I had more time and we could have talked more about, and unfortunately we ran out of time. And Hargo, it's amazing to have you in the studio. Are you happy with us?
Yes,
the program?
Thank you so much.
Yeah, and really thank you very much for being with us. I'll see you. Maybe we'll meet up in some other program. So, so far today we talked about ischemic heart disease and coronary artery bypass. It's a special subject. We didn't have much time, but we somehow gone through the majority of the stuff which you need to know. But you can always check in the NHS website for more details, or you can always ask us questions on our Facebook link or on our Twitter, or you could email us on healthtalk@iron.co.uk. And it was really nice having you all here. Thank you for staying with us on Iron's Health Talk with Dr. Akram. If you have any further questions, please email us healthtalk@irntv.co.uk. Don't forget that. And Facebook and Twitter, you can always follow me. And it's really nice having you all here. And until I see you next time, look after yourselves. Goodbye.